up here at Children's National. And one of my favorite topics of all time is thoracic and abdominal trauma, and which is why I'm doing trauma research, but in the pediatric world. So hopefully this is, it's kind of very broad and it kind of goes over some basics of trauma, but hopefully at the end, you'll understand why we go over this for especially thoracic and abdominal injuries. So why should we care about trauma? I mean, this is Trauma Core. You're doing a whole day of trauma lectures. Why does it matter? Well, injury is the most common cause of death in childhood. Not only that, it's the most common cause of disability in childhood. On top of that, when you're in with injuries, the leading cause of death in trauma is TBI. But this is why it matters. The leading cause of preventable death in trauma is bleeding. So throughout this lecture, I'm going to harp on you guys that you should always, always, always be thinking about bleeding. So to get into thoracic and abdominal trauma, we have to go over the basics of a trauma resuscitation. So when we get called down for our trauma stats or trauma stat attendings or trauma transfers here, we do the same protocol every single time. And when you're in a high stress situation, it was really hard to remember all the caveats to medical decision making. And so the advanced trauma life support has come up with a very simple mnemonic, and it's the ABCs of trauma. So you do this every single time. Now, this is designed for rural community hospitals where it's one doctor, one nurse, and that's all you have, and you have no resources. But here at Children's National, you're a level 1 trauma center, so you have everyone doing everything at once, but we're still hitting these main points. So the first step is checking for the airway, checking for breathing, making sure that the breathing mechanics are intact, circulation is intact, checking for disability, such as is there a neurological disability, is there a long bone fractures or compartment syndrome, and exposure, making sure you look every single part of that person's body and making sure that they don't become hypothermic. So with airway compromise, when you have a child who can talk, it's the easiest way to ask them and make sure their airway is intact is 2 questions. What is your name? And is this what your voice normally sounds like? Because you can have someone say, yes, my name is John, but they have stridor. Well, that to me is an airway compromise that you have to take into consideration. Now this gets, in pediatrics, it gets more complicated when you have the infants and toddlers. So you have to do a lot of observation. And in trauma, just looking at the patient can tell you a whole lot of information. So in kids, you can look and see if they have significant facial trauma. Are they snoring? Is their voice stridorous? Do they have a foreign object in their mouth? Or do they have blood and vomit in the airway? And so we assess that first and foremost, because the first thing that can cause a kid to go into arrest is respiratory arrest, okay? Usually, and we'll get into this in a minute, your circulatory arrest is usually delayed in kids, but your airway can rapidly kill the patient. So we assess airway first. But here's simple maneuvers you can do without getting in a stepwise manner to get the airway intact. If the kid is snoring, doing a simple jaw thrust and seeing if that alleviates the snoring is a very simple maneuver that we can do. And we do that in the operating room all the time when we're waking kids up from anesthesia. You do that, you can't really jaw thrust for the entire time they're getting their trauma resuscitation evaluation. So you can put an oral airway in, or you can put a nasopharyngeal airway in to alleviate that obstruction. They have blood and vomit in their airway, you can suction their airway, but then you can get into more invasive maneuvers such as bag mask ventilation, and you can intubate them. Now, the key is if you do any interventions, you have to go back and restart your ABCs. So even if I do a jaw thrust maneuver and I put an oral airway in, I go back and I make sure that airway is intact before I move on to the second part. The second part would be the breathing mechanics. So breathing mechanics is making sure that you are able to ventilate, you're able to inspire oxygen and expire CO2, okay? So breathing compromise, this is not an all expansive list, this is just a few highlighted points, but you can have breathing compromise from airway issues, so which is why we do that first. And then if the child has a reduced peripheral oxygen saturation, they have asymmetric chest rise, such as they could have a flailed chest. It's more common in your older kids than your younger kids. No breath sounds on either side, which could be a pneumothorax, could be a hemothorax, could be a hemopneumothorax, could be bowel in the chest. You could have a diaphragmatic injury and you could have the liver or bowel up in the chest. And deviated trachea is a huge sign that you can just look at the patient and see if there's major issues. How do we intervene on some of these breathing issues? And we'll get into this more in detail, but simple things is review your airway maneuvers, right? So we start with A, we can do that. And sometimes that'll help the breathing mechanics. Putting a chest tube in for your hemothorax, your pneumothorax. And the chest tube can tell you a lot of information. You put a chest tube in and you have a massive air leak, still after that tube is in and everything's appropriate, you might have further injuries. You might have a tracheobronchial injury. You might have the tubing might be disconnected. Always check the tubing if there's a major air leak on a chest tube. You can do needle decompressions too. That's usually the first choice, and EMS does that a lot. But we actually, in the hospital setting, especially here, we'd probably just move straight for a chest tube, because going back to, we're going to talk about bleeding a lot. If you have a pneumothorax, a lot of times you're going to have a hemo component to it. And so a needle decompression is not going to alleviate that. And then I have a picture of this because I actually didn't even know about this until residency, a three-way valve bandage. So if you have a kid that comes in and has a major penetrating trauma to the chest and has a big sucking chest wound, just putting a simple bandage on with 3 ways will allow, every time they take a breath in, will suck down on the bandage so they won't get air into their chest. But when they breathe, the air will be able to come out. And so that's also a simple maneuver that if you were out in the field, you could do that until they got to the hospital. Then we go on to the C of the ABCs. And again, bleeding, bleeding, bleeding. Okay, there's different types of shock in medicine, but the top 3 reasons in trauma is going to be hemorrhagic shock, and hemorrhagic shock. Okay, so most of your injuries, even we're talking about thoracic and abdominal trauma, you have to be considering bleeding. Now, we're going to get a little interactive now, and I just want to see if people can give me 5 places that you can bleed to death.
Okay, you got somebody who said femur.
Okay, so long bones, good. Abdomen, very good. Chest, excellent. So actually not the brain. Does anyone know why you can't bleed to death inside the cranial cavity? Now you can die from the massive pressure and but it's not right. It's enclosed. There's not enough space to bleed to death inside the brain. Very good, guys. So we've done abdomen, we've done long bones, we've done chest. What other spaces can you bleed to death in?
A lot of people have also said pelvis.
Okay, good. Yeah, so your pelvis, so chest, abdomen, pelvis, long bone, and don't forget, you can bleed onto the floor, right? You can be exsanguinating out. That's the trick question. Okay, so those are the 5 things we really have to look for in trauma and make sure that there is not any injuries in these cavities. So then we move on to disability. And I have this slide on here because most people think of disability as your neurological disability. But don't forget about your long bone fractures, right? You have a major femur fracture, someone mentioned. Well, what about your compartment syndrome? Okay. And your compartment syndrome, we'll get into this later on, will contribute to the lethal triad of trauma. Okay. So things to look out for is pain, pulse, pallor, paresthesias, and paralysis. And the last thing to go, especially in kids, because they usually don't have peripheral vascular disease, the last thing to go is the pulse. So they're usually going to complain of pain, and then they're going to start having some paresthesias. The limb is going to go cold, and then they're going to stop being able to move it, and then their pulse is going to go. So if you start having some of these P's, you have to consider that this patient might have compartment syndrome if the scenario fits. And then the last part of the mnemonic of ABCs is exposure. So look, and look again. Do not miss the missing injury because we didn't look at the patient. And then the other one, I have a thermometer because the lethal triad of trauma, hypothermia is a major contributor of death and trauma. You can have hypothermia even on a 90-degree day, okay? So exposing that patient, looking everywhere, and getting them warm blankets and warm fluids is essential. So this is a first case scenario that we want to talk through some things. And this is kind of going off of the exposure aspect. So let's see, someone's typed in. Good, very good, Eva. For the first case scenario, can someone read this case scenario and then tell me what you're thinking?
Compensated shock.
Okay, so we have a 12-year-old male who gets shot in the buttocks. There's one hole, bleeding is controlled. You have a clean bandage applied without strike through. What do you think about these vital signs? You said compensated shock, okay. What about this picture? Say you have the clean bandage, you look at this patient and you see blood on the bed, but the bandage is still clean and dry. What are we missing here? What's the key in the scenario? Yeah, there's one hole. So talk through. So, okay, so internal bleeding. Where could this bullet go? Good, it could be in the pelvis. Through and through, okay. There's one hole, so it probably didn't go through and through. But what's one easy physical exam maneuver that we can do that often gets missed because people don't want to do it, but it is essential to do on this child? Good, look at their back, scrotum, GI tract. Great, rectal exam, that's the big thing. There's always, in surgery training, they always say the only reason not to do a rectal exam is if you don't have a finger, which is, it's crude, but in trauma, you really need to be looking in the rectal exam because that bullet could easily get into the pelvis and there could be a penetrating hole into the rectum. And so this patient is bleeding through the rectum onto the bed sheet. So the key is exposure. So in penetrating trauma, I look for every single hole I can find. I find out how many holes there are. And there should be an even number if it's through and through. If there's not an even number, you got to find where that bullet is. Airway, make sure that kid's airway. And penetrating trauma is fairly easy. You can walk, if they're screaming at you and they're talking to you, your airway's intact, their breath sounds are equal and bilaterally, that's easy. Circulation, you're looking at their vital signs and you're continuously assessing them. And then your disability and exposure. Now, are kids little adults? Absolutely not. Kids have very different physiology than adults. And that is very important to know here, especially you guys are going to be here at a pediatric center. But the important thing to know is a 5-year-old's physiology might be different than an 18-year-old. But if you go over to MedStar, an 18-year-old is going to be very different than an 80-year-old, okay? So a few things that are in trauma that are different in kids than adults. The airway is shorter and the airway is more anterior. In infants, it's very hard to do a full crike if you have to do a cricothyroidotomy. Okay, so a lot of times you'll put a needle in their neck if you have to, because the cricothyroid membrane is very small. When you're intubating the patient, especially in as they get younger, you really have to look more anterior to get into the airway. The other thing is if you intubate someone on the A part of your ABCs, it is very easy to right main stem a child more so than an adult. Does anyone know why I say right versus left?
Because the bifurcation of the bronchus, the main bronchus are like the same degree.
Right. So the right bronchus is straighter and the left has more of an angle. So you can left main stem, but it's more common to right main stem because it's more of a straight shot. In kids, the chest wall is more compliant and the bones are more cartilaginous. So kids can have major thoracic trauma and have no broken ribs, versus your adults or your teenagers. Usually the ribs will take a lot of the force and you will have broken ribs. But in younger kids, you can have underlying lung parenchymal disease or trauma and pulmonary contusions without any rib fractures. So if you look at a chest x-ray on a kid and you see some haziness, but you don't see any broken ribs, it doesn't mean there's no injury, because the lung took the force of it. And a lot of times we talked about the airway and the hypoxia can cause a lot of respiratory arrest. That is a major contributor of morbidity and mortality in kids because of that. And the other thing is kids have increased physiologic reserve. So we're going back into the bleeding section. I told you we're going to keep talking about bleeding. If you have an 80-year-old, they usually, when they start losing enough blood, they kind of fall down on a slide and their blood pressure goes down very, very steadily. Kids, on the other hand, they go down, they do fine, and then they fall off of a cliff because they've lost so much blood, but they can compensate for that blood loss without reducing their blood pressure for quite a while, until about 40% of their blood losses has occurred. So kids, you can get really, really behind in hemorrhagic shock versus adults. So you have to remember all these semantics for kids, and that's why we're doing a whole day of lectures on trauma. All right, so case scenario 2, now we're kind of getting into the nitty gritty of thoracic and abdominal trauma. Can someone read this case scenario for me?
Eight-year-old boy, pedestrian, struck while crossing road. He is cyanotic, has deviated trachea and distended neck veins. Systolic blood pressure 80/40, heart rate 140, respiratory rate 35, SATs 83 on 15 liters nasal cannula, and DCS of 14.
Good. So the kid hasn't arrived yet. What are you starting to think? What is going through your differential?
Major differential is intrathoracic increased pressure, either hemothoracic, hemothorax.
Yeah.
That's a tension normal.
Very good. Yeah, increased pressure, tension, pneumo, very high on the differential. Very good. So what is your first step? This kid shows up in your trauma bay. What is the first step in assessing this child?
Checking the breathing sound.
Airway.
Airway. Always start with airway. So always do your ABCs. Make sure, is that kid talking or not? Does that kid have any other injuries in the oral cavity? Do we need to intubate this kid right away? Then once you address that, then you can go to breathing. Okay. How would we diagnose this? Let's say, how would I diagnose a tension pneumo in this child? Give me a few examples. There's multiple answers.
Breath sounds.
Okay. So let's say this kid has no breath sounds on the right. You've intubated the patient. No breath sounds on the right. Okay, chest rise. This kid, let's say this kid has bilateral or has asymmetric chest rise. Okay, so physical exam, good with tracheal deviation. What other adjuncts could we use to diagnose this? X-ray, very good. So we can get a chest X-ray. At Children's, we don't use ultrasound as much. We do this more in the adult population, but you can use an ultrasound, and it's called an EFAST, and you can look for lung sliding. If you have a pneumothorax, you won't see that, and we won't get into the details of that, but you could use ultrasound. Chest X-ray is great. So here's the chest X-ray on this kid. Okay, as you can see, the trachea is slightly deviated to the left. The lung is collapsed on the right, and all the mediastinal structures are pushed to the left. Okay, so this is classic tension pneumothorax. Okay, and as you can see, I like this picture because this doesn't have any rib fractures, but this kid still has a tension pneumo. Okay. So how could we intervene on this patient? How would you save this kid's life?
Doc, do you want to do a needle decompression?
Okay. So let's say you do a needle decompression and nothing helps. That doesn't work. Chest tube.
Oh, chest.
Yeah, so chest tube. So needle decompressions in kids is a good idea because most kids are not obese. I say that, but knowing that there is obese kids, but let's say this kid's not. But sometimes the needle actually doesn't get into the thoracic space, and so you don't alleviate the pressure. So I've seen this where EMS comes in, they have bilateral needle decompressions, and it doesn't do anything. So that's why when here at the hospital, we usually put a chest tube in. Does anyone know where we would put the chest tube?
If it's an air, it should be higher, right?
So you just really need to escape it. So a lot of times the safest place to put it would be in the mid-axillary line, right in the armpit, or right below the armpit. It's the fourth rib space. Because usually the kid's going to be laying flat on the bed. And so it kind of gets tough because if they sit up or they lay down, the air is going to change. But really, you just have to release the pressure in the chest. So the physiology of, does anyone know how tension pneumothoraxes actually kill patients? This is probably a higher level question, but I think it's important.
Because the compression pressure also transmits to the heart.
Very good, excellent. Yeah, okay, great. Yeah, so it's not the pressure and it's not from the lack of oxygen saturation. It's really due to it compresses the preload on the heart. So you have an obstructive shock output. So you're not getting blood back to the heart. And so they have a circulatory arrest usually. And so that's why you have to relieve that pressure. Very good, guys. What other thoracic injuries could this child have? You know, we talked about tension pneumo, but there's lots of other organs and stuff in the chest. What other can this kid have? I guess I accidentally went ahead, but so you gotta think about your simple pneumo. Always think about hemo. That's why we put the chest tubes in instead of needle decompressions, because most of the time they're gonna have blood in their chest. Flailed chest is not as common in kids just because we talked about how their chest wall is more compliant and their chest wall also the bones are more cartilaginous, but they have the pulmonary contusions, which causes hypoxia and proceeds to respiratory failure. Don't forget about your blunt cardiac injuries. They can lead to life-threatening arrhythmias. Your aorta could be disrupted. Don't forget about the diaphragms. Always remember about the diaphragms. Diaphragm injuries are very difficult to diagnose if they're subtle. And then you could have your esophageal injuries. So you put the chest tube in and you still have a massive air leak, or you have a tracheobronchial injury, put a chest tube in, you still have a massive air leak. And so we'd have to intervene on those as well. Okay, case scenario 3. Can someone read this to me?
"15-year-old boy, gunshot wound to abdomen. His blood pressure is 120/30, heart rate is 136, respiratory rate is 35, his oxygen is 93 on 6 liters nasal cannula, a GCS of 15.
Good. So looking at this blood pressure, what stands out about this blood pressure? Why did I make the diastolic low?
You look that the peripheral resistance is going down somewhere.
Right, yeah, so they're losing blood. So usually you'll see a very widened pulse pressure initially before the systolic drops. And then the heart rate goes up, respiratory rate's up. It's kind of weird. This kid gets shot in the abdomen, but we're having oxygenation issues, we're having respiratory issues. So what could be going on? And I'll give you a hint. I talked about there's one organ that's very difficult it's very subtle when it's injured.
Diaphragmatic injury.
Very good. Yeah. So this bullet could have easily tracked up into the chest through the diaphragm. So if you look at this, you can see on the chest X-ray that you have bowel up into the left chest. Okay. Now, don't forget that when you have infants and you get a chest X-ray on an infant who's been crying, you can have a very large gastric bubble. And so you have to take the clinical situation into context too. Okay. Okay, so updated vitals. Now this kid's blood pressure is 80/30. Heart rate's 155, still tachypneic. Now we're on 15 liters and the GCS has dropped to 8. Why is that GCS 8 now? We only have one, you found the bullet, you have one hole, you know where the bullet is, but why is this kid's GCS 8 now? Good, good. We're not perfusing the brain, right? You start losing blood volume, your GCS is not gonna, you're gonna get confused and stuff. So what do you wanna do next? What's the next step? You have this change in vital signs. What do we do? Okay, so we could do volume. Okay, so you give volume, now the kids' oxygen saturations are 80%. Yeah. So very good. Yeah, so we're talking about the mnemonic is 8 or less intubate. What I guess is more know what I'm thinking. I want you to go back to your ABCs. You have a major change in your vital signs. Start back. Is the airway intact? Yes or no? Is the breathing intact? Yes or no? In that, you would intubate the patient, right? Because their breathing is not intact. They're not protecting their airway. Their GCS is 8. So go back to your ABCs and start back over and go airway, breathing, circulation, disability, exposure. Okay. And good, the volume is important. Okay. Now, what type of volume would we want to give this kid? Good, blood. So right now, the advanced trauma life support current recommendations is to give crystalloid first. That is starting to change. And later today, Zach is going to go over some of our research that we're going over with giving blood first. If you're in massive transfusion protocol, you do a 1-to-1 ratio of blood to plasma to platelets. Now, the caveat with that is platelets it's a 6-pack of platelets. So every 6 units of blood, you give a unit of platelets. But it's 1-to-1 that way. But good, you want to give blood. You want to give warm blood or warm crystalloids because this patient is quickly going to become hypothermic. Okay. So this patient likely is in hemorrhagic shock. You want to intubate this patient, restart your ABCs, intubate the patient, and you want to start transfusing this patient. So I bring this up because this is a very good diagram of the classes of hemorrhagic shock. So class 1 hemorrhagic shock is your kid has lost about 0 to 15% of their blood volume, but their vital signs are normal and they're really just a little anxious. You know, your typical child who comes in and they're nervous. Class 2, you're 15 to 30% of your blood loss. Class 3, you're 30 to 40%. And class 4, you're greater than 40% blood loss. Now, I've highlighted class 4 because it's usually where your children will start to show vital sign derangements. When you're an adult, it usually starts in class 3, okay? So this is a very good table that really illustrates the fact that kids have a very high physiologic reserve and really don't start showing hemorrhagic shock until their blood volume is lost about 40 to 50%, okay? It's very important to have a high index of suspicion for bleeding and trauma, because when the kids start becoming hypotensive and tachycardic, you really have to start resuscitating them very, very quickly. So then we get into the topic of, well, how's the difference between penetrating trauma in the abdomen and blunt trauma in the abdomen? And a lot of they're very different unless the kid is an extremis. If the kid is an extremis, you just take them to the operating room, irregardless if it's penetrating or blunt, and you have evidence that there's an issue there. But in penetrating trauma, we really, if you have a bullet hole or a stab or anything that is impaled through the fascia of the abdominal wall, we take the patient to the operating room. If there's any hemodynamic instability, you start transfusing them and you get them to the operating room. But you remember, you have to expose the entire body. You cannot miss an injury. Okay, so if some kid comes in and they're shot in the abdomen and you just take them straight to the operating room, but you missed the bullet hole in the back and you didn't prep the patient for a thoracic surgery, then it's going to be a whole lot of problems. So always look for every single hole, and it doesn't take that long to look. Sometimes you can, if they're stable and their GCS is appropriate, you can get adjuncts to help localize injuries. Sometimes you can get them to the scanner under certain circumstances, but X-rays sometimes can help you find where the bullets are and where it tracked. And I've seen where some kid is, or it was probably an adult, got shot in the neck and the bullet tracked all the way down to the right leg and went right through the diaphragm, right through the liver, all the way down. So bullets can travel. Blunt abdominal trauma is a little different, okay? So if you get shot in the right upper quadrant or you get stabbed in the right upper quadrant, you're gonna take them to the operating room and you're gonna XLAP them. But blunt abdominal trauma is different, right? You're in a high-speed motor vehicle crash or you're in a ped struck. You know, you could have other abdominal traumas. You could have liver lax, spleen lax, you could have bowel injuries, retroperitoneal injuries. Don't forget about the uterus. Always, especially in kids, it's easy to forget that they could be pregnant. They could have an enlarged uterus. So don't forget about all of those reproductive organs too. Okay. The thing about blunt abdominal trauma is there's usually an algorithm for blunt trauma in the abdomen. Again, if you're hemodynamically unstable, you have peritonitis, you're going to just take them to the operating room. You're going to find out what's going on. Otherwise, most blunt abdominal trauma or solid organ injuries can be managed conservatively. Okay. So a lot of times these kids will come in, they'll have a grade 2 spleen or a grade 2 liver, and there's out of 5, and we'll observe them. And you usually observe them for a few days, or you follow them closely outpatient to make sure that they don't have any other issues. Sometimes you'll get into like a grade 3 or grade 4 splenic laceration, and sometimes they'll have a pseudoaneurysm, And those usually will start if the pseudoaneurysm ruptures, it's usually 3 or 4 days later. So that's why we observe them. But a lot of times these kids don't need any operative interventions other than observation for solid organ injuries. And then the final thing is, I'm hoping, I guess we're going to be done a few minutes early, is kind of bringing everything all together. And I know someone had mentioned this earlier, and they correctly said the lethal triad of trauma is coagulopathy, acidosis, and hypothermia. Okay. The reason why the ABCs are so important is because they all help fix these issues. So airway and breathing, you can have a respiratory acidosis. Okay. If you're not breathing and the GCS is less than 8, they're not expiring the CO2, they're going to become acidotic. Or in the reverse, if the patient is tachypnic and they're having respiratory issues and they're breathing very shallow and rapid, they're going to tire out and eventually go into respiratory acidosis. 2, breathing also, when you're acidotic, will cause coagulopathy. Okay, so your clotting factors don't work when you're acidotic. Circulation, you can go into DIC. You're bleeding too much, you use up all your clotting factors, and then on top you're acidotic, and they're not even, the little that you have doesn't work. You have breathing can impact and circulation can hit into coagulopathy. Going back down to hypothermia, when you're in hemorrhagic shock, you start vasoconstricting and you shunt blood to your brain and your heart. So everything else will not get perfused and everything else becomes cold. And that's why trauma patients very quickly can become hypothermic. And hypothermia will worsen your acidosis, it will worsen your coagulopathy. Finally, on disability, don't forget about your compartment syndromes, okay? When you're in compartment syndrome, you also become acidotic because your lactic acid starts going up. And then you can start becoming coagulopathic from that as well. And then finally, we haven't touched on this much, but I really want to belabor this point. Exposure, exposure, and exposure. Look for everything and make sure that you are warming the patient, because if you don't warm the patient, they're going to be hypothermic, they're going to become acidotic, and they're going to become coagulopathic. Okay, so in conclusion, I really want you guys to remember your ABCs of trauma. Don't miss an injury. Every single trauma patient that comes in, even if their GCS is 15, their blood pressure, heart rate's normal, you need to make sure that they are not bleeding. Children are not tiny adults. They have very different physiology. Penetrating and blunt injury types may have different management strategies, but if you're an extremis, they're the same. And then the lethal triad of trauma and how this corresponds with the ABCs and why we really belabor the point of assessing your ABCs, because you're going to change someone's life. I hope that was good and interesting. And if you guys have any questions, I'm happy to answer.